Good day. Today I would be giving a small talk on acute pulmonary hemorrhage, a life threatening emergency in the post neonatal period. Now, the case scenario is that a 6-year-old female, failure to thrive, history of recurrent episodes of cough, fast breathing since infancy, was hospitalized for fever, cough, fast breathing for 4 days, and refusal to feed for a day. On examination, her heart rate was 106 per minute, respiratory rate 66 breaths per minute, SpO2 93% in room air. She was anemic, had grade 2 clubbing, bilateral chest retractions. However, air entry was equal with bilateral cramps and wheezing. She was kept on oxygen by prongs at 4 liters per minute, nebulized with salbutamol and Budecort, given antibiotics, IV fluids. This is her chest X-ray, which shows evidences of bronchiectatic changes and consolidation. Her hemoglobin was low, total leukocyte count was 14,500, 85% poly, and C-reactive protein was 65 milligrams per liter. After 2 hours, her SpO2 fell to 85%. Oxygen flow was increased to 6 to 8 liters per minute with no improvement. She had a bout of cough, massive hemoptysis, and collapsed and was taken to the PICU. Now, she had a massive pulmonary hemorrhage. 5% of those requiring ICU care suffer from massive pulmonary hemorrhage. Mortality rate is high, ranging from 30 to 50%, and the causes are variable. So today I'll be telling you about the definition and pathophysiology, differential diagnosis, causes, clinical findings, investigations, management, prognosis, and in the end, some take-home messages. Now, pulmonary hemorrhage is a rare condition out of ICU setting. It affects children of all ages. A triad of hemoptysis, anemia, airspace opacities on chest radiograph are suggestive, and it can present silently, which delays the diagnosis, or as an acute life-threatening event requiring resuscitation. Bleeding may be diffuse or localized. Now, the lung receives blood from two separate circulations, the bronchial circulation, which is high pressure, low volume circuit, via the bronchial arteries of aorta, and bleeding from bronchial circulation is profuse, massive, and can cause death. The pulmonary circulation is low pressure, high capacitance circuit from the right ventricle. Bleeding from the pulmonary circulation is low grade, and it can be chronic and diffuse. Now, this is the diagram: left ventricle, the aorta, and the systemic circulation. It gives the bronchial circulation, and from the right ventricle you have the pulmonary arteries. Remember that there are two bronchial arteries on the left side, and the bronchial artery on the right side comes usually from the third intercostal artery. Now, the features differentiating from hemoptysis and hematemesis. Hemoptysis, there's a prodrome of tingling in the throat or gurgling in the chest, whereas in hematemesis, there's a prodrome of nausea, abdominal discomfort. In hemoptysis, blood is coughed out. In hematemesis, blood is vomited out. Hemoptysis, it's frothy, bright red in color, whereas in hematemesis, it's purple, brown, coffee ground in color. It's mixed with sputum in hemoptysis and may contain food particles in hematemesis. It is preceded by cough and followed by respiratory distress in hemoptysis, whereas hematemesis has no distress. In hemoptysis, there is history of pre-existing lung disease associated with chest abnormalities, whereas hematemesis can have pre-existing liver GI disease with and may be associated with jaundice. Now, is this massive life-threatening hemoptysis? The practical definition of massive or life-threatening hemoptysis is when it's associated with one or more of the following: signs of respiratory distress, signs of airway obstruction, evidence of abnormal gas exchange, and the patient becomes hemodynamically unstable. Could be focal or diffuse, and parents and clinicians are poor in estimating the volume of blood expectorated. So, the focal pulmonary hemorrhage is restricted to the lung, is subsegmental, segmental, or lobar, and can be life threatening. Now, what are the causes of focal hemorrhage? It could be infections like bronchiectasis as a result of cystic fibrosis, primary ciliary dyskinesia, TB, lung abscess, pneumonia, bronchitis. Congenital malformations like pulmonary sequestration, CPAM, bronchogenic cyst, bleeding diathesis of various causes, trauma to the lung, vascular abnormalities, and miscellaneous causes like primary capillary hemangiomatosis. The diffuse alveolar hemorrhage occurs as a result of disruption of the alveolar capillary basement membrane in the lung with resultant bleeding into the alveolar spaces. Injury can be immune or non-immune mediated with subsequent involvement of blood vessels and the alveolar septae. Can sometimes present as a life-threatening event. Now, what are the causes of diffuse pulmonary hemorrhage? They could be without capillaritis, non-immune, for example, non-cardiac like idiopathic pulmonary hemosiderosis, Heiner's, idiopathic pulmonary hemorrhage of infancy, celiac disease, etc., or vascular like mitral stenosis, pulmonary veno-occlusive disease, chronic heart failure, or it could be with capillaritis, immune mediated like idiopathic pulmonary capillaritis, Wegener's, SLE, Churg-Strauss, etc. Now, in a publication in 2019, retrospective chart review was done of 44 children with a mean age of 59 months. 28 were boys admitted with pulmonary hemorrhage. Possible idiopathic pulmonary hemosiderosis was seen in 16 of them. Immune-mediated disorders in 8, which is 18.2%. Post-infectious complications in 11, 25%. Cardiac and vascular defects in 7, 15.9%. And airway pathologies in 4.5%. Now there are diagnostic clues from the history. History of acute fever, cough and chest pain as pneumonia, suggestive. Prolonged fever, cough and weight loss, suggestive of TB. Recurrent cough and productive sputum in bronchiectasis. Dyspnea on exertion, fatigue and nocturnal dyspnea, frothy pink sputum in cardiac. Immobilization history, chest pain, calf pain, pulmonary embolism. Uncontrolled asthma in ABPA, Churg-Strauss syndrome, and travel to endemic area in TB, schistosomiasis, and paragonismus. There are diagnostic clues from examination like pallor, clubbing, growth failure, cardiomegaly, hypoxemia, in chronic recurrent bleeding, dullness to percussion and crepitations and rub in pneumonia, unequal chest wall movement, air entry and localized wheeze, endobronchial growth of foreign body, allowed P2 with a diastolic murmur, cardiac, telangiectasia or hemangioma, pulmonary AV malformation, bleeding from other sites, bleeding diathesis, hypertension, pleural rub as in collagen vascular disease, episcleritis, uveitis, retinal vasculitis and vasculitis syndromes, nasal septal erosion or ulcer in Wegener's granulomatosis, and skin rash in leucoclastic vasculitis. Now the investigations would be for the etiology, for infective causes, counts, full blood counts, ESR, CRP, sputum culture, imaging, CT, X-ray, Bleeding disorders, coagulation studies, von Willebrand factor, D-dimer. Immune mediated, you have various immune antibodies like IgG, ANCA antibody, anti-glomerular basement membrane, APLA, ANA, anti-double stranded DNA, anti-smooth muscle, urinalysis, plaque biopsy if required, and genetic studies. For cardiac causes, echocardiogram with bubble test. For vascular abnormalities, imaging with CECT, CTA, CTPA or angiography, MRI angiography, and in airway disease and trauma, bronchoscopic, fiber optic, or rigid. Now, what about radiology? Chest X-ray, there's no pathognomonic radiological finding for pulmonary hemorrhage. It could be normal. Portable chest X-ray may be helpful in localizing the site of bleeding in minority of cases, but has poor diagnostic accuracy. And important etiological clues can be gained. If there is unilateral air trapping with hyperinflation, it may be suggestive of foreign body. Now here it's a 6-month-old child with pulmonary hemorrhage. 1A is showing bilateral patchy parenchymal infiltrates with normal cardiac silhouette and mediastinum. 1B is the axial image of contrast enhanced CECT showing consolidation left more than right. 1C is the coronal image CECT of chest showing no mediastinal pathology, and 1D is coronal image parenchymal view CECT showing bilateral consolidation. 50% of patients with normal chest X-ray have contributory findings on CT. So chest X-ray should not be done if it delays time to CT. And CT scan in lateral decubitus position and bleeding lung down to avoid contamination of the contralateral lung can be done. Now what about bronchoscopy? Early bronchoscopy is indicated to document alveolar hemorrhage, site of bleeding in focal cases, to exclude infection, to perform certain therapeutic procedures. Fiber optic bronchoscopy allows more detailed evaluation of distal bronchial tree, and rigid bronchoscopy permits effective ventilation and removal of blood clots of foreign body. Now the previous X-rays were from the same publication by Nath et al. Here, this is a bronchoscopic findings. 1A is showing dilated submucosal blood vessels at the carina leading to the left main bronchus, and 1B is showing dilated blood vessels in the submucosal region of the left main bronchus. Endobronchial changes with dilatation of the dense submucosal venous plexus can often be seen in bronchoscopy. Again, this is bronchoscopy, dead dichromatic imaging mode. It is showing blood coming out from the right middle lobe. Here you can see that. The diagnostic accuracy of bronchoscopy is inferior to CT chest in localizing site of bleeding. It should not be used as a replacement of CT chest and should be considered as an adjunct to CT chest. In some cases, bronchoscopy may be the only option available for patients who are too unstable for transportation to CT, and installation of endobronchial epinephrine or tranexamic acid can be done. Bronchoscopy can be complementary to CT and provides source control measures such as balloon tamponade with bronchial blockers as shown in the image below. Now, pulmonary function tests are not indicated. Child may not be able to perform in acute stage. However, if done, an obstructive pattern is observed in acute hemorrhage and restrictive in chronic cases. There's increased diffusing capacity of carbon monoxide. This is a characteristic feature. And exhaled nitric oxide is decreased. These changes, however, are not diagnosed. Now we come to the general measures in management. To reduce hypoxia, we give oxygen either by non-invasive mode, or patient may require intubation with adequate PEEP. We can do lung isolation in focal bleeding with the affected lung downwards in Trendelenburg or reverse Trendelenburg position, correcting anemia. We require to give PRBC transfusion and correcting any coagulopathy if platelet count is less than 50,000. Then platelet transfusion if INR more than 2, FFP transfusion 15 to 20 ml per kg. If fibrinogen level is less than 1.5 grams per liter, then a cryoprecipitate transfusion. And we have to do reversal of anticoagulants with prothrombin complex concentrates or direct inhibitors. We have to do hemorrhage control measures prior to source control. We can give nebulized tranexamic acid for less than 25 kg 250 milligrams, and for more than 25 kg 500 milligram in normal saline 6 hourly, 3 to 4 doses for 24 hours. Then tranexamic acid IV loading 10 to 30 milligram per kg single dose over 10 minutes, followed by IV infusion. The severe complications are there like seizures, pulmonary embolism, deep vein thrombosis, impaired vision. Factor 7A infusion orphan use 225 microgram per kg IV. 6 hours later, 75 microgram per kg IV. Every 2 hours till there's hemostasis, and bronchoscopic instillation of factor 7A can be done. 75 milligram per kg in 50 ml fluid. Additional measures in cases of massive focal pulmonary hemorrhage: endoscopic balloon occlusion of a lobe or main bronchus, topical airway vasoconstrictors, use of special CO2 laser bronchoscopy, transcatheter embolization of bronchial vessels, and even lobectomy. Now, additional measures you can do: bronchial artery embolization. Selective embolization of bronchial artery is technically challenging, but immediate cessation of hemorrhage can be achieved in about 3/4 and control beyond 3 months and 45%. Complications include transient fever, chest pain, back pain, dysphagia, ball necrosis, and transverse myelitis. Additional measures in massive diffuse pulmonary hemorrhage, which is of immune origin and life-threatening, we can give autoimmune IVIgG or go resort to plasmapheresis. The commonest cause of mortality in acute cases is asphyxiation, followed by respiratory failure and hemorrhagic shock. Prognosis primarily depends on underlying etiology and severity of pulmonary hemorrhage. In cases of idiopathic pulmonary hemorrhage, clinical course is highly variable and prognosis overall is poor. The higher the age at diagnosis, if there's history of hemoptysis, jaundice at presentation, it is predictive of poor prognosis. So take home messages: massive pulmonary hemorrhage is a life-threatening emergency diagnosed by severity of vital signs. Immediate management is essential. Manage hypoxia, anemia, coagulopathy, which can be done in level 1. Hemorrhage control prior to source control can be done in level 1 or level 2. And only necessary tests, if available, can be done to establish whether it's focal or diffuse for additional management. And when the patient is stable, definitive diagnosis can be made. Thank you very much for your patient hearing.